Hit the subscribe button or visit us at auau.auanet.org.
I'm going to go ahead and get started with the second part of our program. Hope you all had a good lunch and some time to relax. We'll go ahead and start the next talk. So this is a little bit out of sequence because of our accommodation, but this talk will be on non-metastatic or M0 CRPC. These are my disclosures. So we'll go a little bit over the background, talk about selecting patients, not too unlike Dr. Borjan's talk where he talked about high-risk rising PSA patients who are untreated. Then we'll talk a little bit about the guidelines, our studies that led to the approvals and the agents that are out there. So you guys probably saw the 2023 prostate cancer statistics, but the usual, there's always the number one incident cancer and high number. But what was a little concerning is this increase in newly diagnosed advanced or metastatic prostate cancer, which has increased over the past several years by about 5% for these advanced disease states. And part of that's a consequence of kind of the anti-screening and the backlash. Some primary care doctors just don't do it. Some of it's access, some of it's just education. But if we don't do a better job there and that number keeps increasing, most of these patients are not curable. They're just treatable and manageable. So we'd really like to see a change in that. And the only way we'll have reductions in death is through earlier detection and treatment for those earlier stage diseases. So that's kind of why I stuck it in there as a reminder. So why focus on these non-metastatic CRPC patients? And the kind of the rationale is here, but lower tumor burden may be offering us an opportunity to have a more durable response, advancing these more effective therapies. So many of you know that almost all the treatments that we talk about today were trialed initially in patients with castration resistance who'd failed almost all other therapies available at the time that they were enrolled. And so we see examples, and I just have a couple of them here, but and Alicia Morgan showed enzalutamide post-chemotherapy as it was initially introduced, then pre-docetaxel chemotherapy in the CRPC state, then in the M0, and now even in the metastatic. And each time these drugs move forward, say docetaxel had 3-month survival advantage in the original castration resistant, but then when they moved it into the metastatic state, 12 to 18 months of survival benefit. So these drugs work better when they're given to patients who are able to take them, as well as when their disease state is less. So that's kind of the rationale. And delaying metastases is an important event. At the time that the FDA was looking at approving a drug, usually they went with survival, but they bought in that metastasis-free survival and delaying the development of metastasis or death is an important clinical endpoint. So this window of opportunity is there, but it may close quickly. We've kind of already been through the mechanisms of action, so I don't have to do that, but you do know that these kind of second generation AR targeted therapies, they work at the cellular level, they work intracellularly, and then they block even within the nucleus. So these are all reasons why they're 10 to 20 times more potent than what we used to have available, such as bicalutamide and the first generation agents. When the original M0 studies were being developed, it was serendipitous that they were looking at bone-targeted therapies in these non-metastatic patients, and they were following them, and they discovered that that doubling time when they were screening patients, ultimately that predicted the development of metastatic disease. And so when they were looking at those patients who are non-metastatic but at risk for developing those metastatic deposits and then designing clinical trials, they enriched them to target that 10-month period because they could see that if your doubling time was 10 months or less, you were predictably likely within a couple of years to develop that metastatic event. And so it wouldn't take 10 years to do your trial. So the guidelines here state that you should follow these patients along when they are non-metastatic and do periodic interval tests and we know that. So usually they're getting PSA tests. Traditionally, they were getting conventional imaging, and as Dr. Stratton's talk highlighted, now using PSMA imaging is certainly an option for most of us, and probably a preferred option in those who have access to it. So really just following them along, monitoring, and looking for the development. This gets back to the drug, approval when they were doing the trials, what they thought was a meaningful endpoint, and really it was the first time in prostate that we'd had this metastasis-free reasonable endpoint, and then 3 of these AR-targeted drugs developed their studies to try and approach that. I remember many discussions of people would say, like, well, what would be a meaningful delay in the development of that? And there were a lot of debates about 3 months, 6 months, and nobody really thought it would be much longer than that. So, and then none of the medical oncologists, and I don't know how many besides our faculty are here in this room, but the medical oncologists really didn't like the metastasis-free endpoint because they really wanted to see overall survival benefit. So with that in mind, they came up with that new regulatory endpoint of metastasis-free. They really didn't know how that might translate into overall survival, but it was meaningful to patients, and so the studies started. These are sort of in alphabetical order by their drug, active agent. So apalutamide in the SPARTAN trial was the first trial. You'll see similarities, so we won't have to go through all the designs, but basically patients with non-metastatic disease, rapid PSA doubling times of 10 months or less were enrolled. This study, the SPARTAN study, did include patients with pelvic nodes, and so it comes up like, what if they had a PET scan? We know that 20, 30% of these would have had some discoverable metastatic disease on their PSMA, and probably a lot of them would have had nodal involvement. And they were randomized 2-to-1, so they had, all of them had continuous ADT, and then there was a placebo as compared to the apalutamide in the active agent arm, and metastasis-free survival was the endpoint there that they were looking for as a primary goal. The median PSA doubling time in these studies was 4.5 months, so you can see that these patients were sort of headed for trouble, and so that helped to be able to get to the primary endpoints or not much quicker. And this was their overall metastasis-free survival benefit, which was highly significant, so about a 30% risk reduction in development of metastatic disease and or death from prostate cancer using the active agent. The side effect profiles of these have already been reviewed in other talks, but we know that there's an association of some side effects to all of these, and peculiar to the apalutamide was rash, for example. So people were seeing rashes, and at first they weren't really sure how to manage them. I think most were able to stop the medication, the rash went away, and then resume the medication after that. There was also a small amount of patients but that had hypothyroidism, so we usually monitor a little bit of thyroid function testing baseline and then periodically while they're on active treatment as a result of that. So this was the translation. I remember I said, people would get polled and they'd say, is it 3 months? Is it 6 months? How long would it be? And you can see that there was almost like a 20-month improvement in the active treatment arm as compared to the placebo. So that was not expected to be that much of a difference. So that was very good news. These patients oftentimes are only having side effects from their hormonal therapy, so they're non-metastatic, they're not having bone pain, so it was important to do some patient quality of life studies, and basically these showed that their quality of life was maintained while on these therapies. It wasn't significantly hindering it. And then they did extended follow-up because, again, people wanted to see what would really happen. Was it just a delay in the inevitable, and would it matter? But then that metastasis-free survival translated in this study and the subsequent ones that I'm going to show you into an overall survival benefit, and you can see there it was like 13 months, so more than a year of benefit just by instituting a therapy earlier to extend their overall survival. I'll back up and notice too how long these patients are living today. So, when we very first started doing castration-resistant anything, it could be any drug, any trial, the average life expectancy was like a year and a half. With more additional therapeutics to these patients, now they're living 4 and 5 years, even in the face of widely metastatic disease. So we have been able to push it out, even though we haven't been able to cure it. The second study is this Aramis study using darolutamide as the active agent. Again, very similar trial design, enriched with patients with rapid PSA doubling times. Metastasis-free survival was the endpoint. These patients also had rapid doubling times of around 4 to 4.5 months. The average PSA when they were enrolled was in the 9 to 10 range. Again, significant improvement. The hazard ratio here was 0.41, so pretty significant improvement in the delay of development of that metastases or death from disease. Side effect profiles are shown here. When I show these, I'm showing them for completeness, and they're in your book so you can go and look. But what you really shouldn't do is say, well, I noticed that drug A had this much fatigue, and drug B had this much fracture, and drug C had this much hypertension, so that must be that this one's better than that one. And unless they're compared head-to-head in a study, really you can't extrapolate the adverse events and compare them directly. So there's just a little bit of a caution. And again, continuing with the darolutamide side effect profile as shown here, the drug was very well tolerated. And again, getting back to those patient-reported outcomes, not only were there not detriments to their health, but there were improvements in some bowel and urinary symptoms. So there was some benefit from a local standpoint in addition to the survival benefit. So this was the metastasis-free survival. Again, we're looking at more than 20 months of benefit. And then just like the study I showed you previously, they extended the follow-up and had enough to look at overall survival, and there was a significant improvement in overall survival as well, instituting the therapy in that M0 disease state. There were other parts to the study and secondary endpoints like institution of cytotoxic chemotherapy, time to skeletal-related event, first skeletal-related event. Again, all these kind of secondary endpoints which were significant and improved. The third drug, enzalutamide here in the PROSPER trial, and you've heard about enzalutamide in other disease states of metastatic as well as castration resistance, but in the M0 space, the PROSPER trial. Again, similar rapid doubling times for enrollment in the study. Their PSAs had to be greater than 2, and then they were randomized 2 to 1 with the metastasis-free survival endpoint. You can see the rapid doubling time, less than 6 months in about 77% of these patients. This was their Kaplan-Meier curves that showed significant improvement again, very similar to the other trials and with the active agent. The adverse events are listed here, and you can look through those as well. But again, typical things such as fatigue and increased hot flashes and that sort of stuff. Notice the grade 3 toxicities in all 3 of these studies. That would be like have to discontinue the drug or get off the study. Those were very low. Primary endpoint was met, metastasis-free survival. Again, greater than 20 months benefit, so that was significant. Stable on the quality of life improvements, so all 3 studies demonstrated those patient-reported outcomes to be stable or improved. And then the overall survival benefits similarly came through for the enzalutamide, and again extended the survival by more than a year for these patients. So the guidelines here state that you should offer patients with non-metastatic CRPC who are at high risk for developing metastatic disease, and in the trials that was defined by that doubling time of less than 10 months, either apalutamide, darolutamide, or enzalutamide. Patients with slower doubling times may be appropriate for observation, so not all patients in this space need to be treated. And there's currently no role for chemotherapy and immunotherapy in that M0 patient has really not been studied. So summarizing this, patient selection is important in the M0 space. The metastasis-free endpoint was a significant endpoint, and you're going to see in the next couple of years others, and there's even, I think, one being presented at the AUA this year that will show that metastasis-free survival endpoint is now something that many are gunning for, because the hope is it will translate into OS, but it's an important and meaningful endpoint and could lead to approval. Clinicians should offer these drugs with continued ADT in the M0 space. We showed that not only prolongs their metastasis-free survival, but their overall survival, and then the quality of life appears to be maintained. So there's good footing for the guideline recommendation of these three active agents based on their trial data. Interestingly, on their FDA approval, they're not restricted to that doubling time, so that's really kind of nuanced by people reviewing in the guidelines. So, if you had somebody that had a doubling time that wasn't quite approaching 10 months but close, you could certainly be under the FDA guidance to administer that. And the decision for all these treatments, of course, is going to be based on risk-benefit profile.